graphic is just to show that there are different symptoms and complications associated with different impacts on the organ system level. So, affecting the heart, yes, the respiratory system, but also potentially kidneys and the joints, mental health and the nervous system, the metabolic system and the endocrine system. So energy and hormones, digestion, the skin, the blood, and systemic issues like fatigue and anemia and ongoing fevers. So literally it can affect you from your head to your toes. We had hair loss down to COVID toes was one of the early manifestations of this. Next slide, please. So while most people who have an acute COVID-19 infection do go on to make a full recovery, there is a subset of people who will go on to have longer term issues. They might have persistent symptoms, meaning the symptoms from their acute infection don't quite go away, like they're still coughing, they're still tired. Some people may experience early complications from other conditions. It might be like a tipping point, essentially, for things like diabetes, dementia, kidney disease, and other underlying chronic conditions that might be unveiled or made worse by a COVID-19 infection. Or somebody might have new symptoms, and these longer complications can happen even after it seems like somebody maybe recovered from their acute infection, but then several weeks or a couple months later, they start having these new symptoms like this really profound fatigue or brain fog and issues with their memory. So long COVID is really all of these things. People use the term long COVID to describe any of these scenarios. One thing they have in common is that people who are having severe versions of these complications may need help. They might need long-term monitoring from a healthcare provider, mental health support, rehabilitation, or other social services support. Next slide, please. And some of the underlying causes are still being explored. Some of the theories that are out there include direct tissue damage from the virus. So we may see this in the lungs or in the nasal area. Autoimmune triggers, so it can show up as like a new autoimmune condition for people where the body starts kind of attacking itself. There's a theory about microclots. The slide on the right there is showing some, they just look like little fluorescent dots on a slide, but they're showing platelets in some blood samples from people who had COVID and then experienced long COVID. And what it shows is this hyperactivation of the platelets in the blood. So that makes them stick together and form these little clots that can really wreak havoc on the body. There may be ongoing inflammation from viral reservoirs, meaning people aren't completely clearing the virus. There may be reactivation of other viruses like Epstein-Barr virus or herpes viruses. There may be some evidence that there's changes to the mitochondria, which is the powerhouse of the cells, or it could be a combination of these things, or it could be something else that we're still coming to understand. Next slide, please. One thing I forgot to mention at the beginning of this presentation, and I've got it on the bottom of all of our slides. We're learning more about this all the time. There's new evidence coming out almost every day. So the information I'm presenting today is current as of today, which is September 26, 2003. Information may change as we learn more. And so we try to keep our website up to date with the latest, and we'll provide that information near the end. But I just want to say that this is current as of today. If you're viewing the recording at a later date, you may want to check on some of this. And also, if you've seen me give this presentation in the past, you may see some new or different information this time around. Okay, so what is long COVID? I've given you all these like scary scenarios of the virus wreaking havoc on the body. What is long COVID? Well, like I mentioned, it's not really one condition. There's these different scenarios that we kind of call under this long COVID umbrella. There are multiple definitions out there from the CDC and the World Health Organization and others. But generally, they consider it to be a wide range of new, returning, or ongoing health problems people can experience 4 or more weeks after first being infected with the virus that causes COVID-19. The World Health Organization has a similar definition, but they kind of start the clock at 12 weeks because a lot of people will take, maybe 6 weeks to recover from COVID all the way, or 8 weeks. And you want to be careful about not kind of over medicalizing this, that, some people just take longer to get better. So they kind of started at 12 weeks, and they also added that it can't be explained by another health condition, which is important because a lot of these symptoms overlap with other chronic conditions. You may hear other terms for long COVID, like long haul COVID or long haulers, chronic COVID, PASC, which stands for post-acute sequelae of COVID-19, post-COVID conditions, and other names. Next slide, please. So what are some of these symptoms of long COVID? Well, I showed quite a few of them on that first slide with all the different organ systems, but different studies have shown over 200 different symptoms can be reported. And again, many other diseases and conditions can cause similar symptoms. So this can make it a little bit hard to pin down what long COVID is. It's different from person to person. People can be impacted very differently. The symptoms may occur in clusters or subtypes, and they're starting to see these different phenotypes emerge where some people seem to really have like the ongoing respiratory issues from lung damage. Another group of people might really be having the extreme fatigue and brain fog. Another group might be having fatigue, but then also pain and tingling in their extremities or different types of joint pain. So we are starting to understand these different clusters, but it is still early days. And these symptoms, as mentioned, can be ongoing from their acute infection, or they may be new. They can also come and go, and that can make this tricky too, is that sometimes people get better for a time, but then something will trigger a relapse, meaning their symptoms come back, and that can be triggered by a number of things like stress, another reinfection with COVID-19, menstrual cycles, changes to the diet, exercise, and other things. And this can go on for weeks or months or even longer. There are people who got sick with COVID in the very first wave in March of 2020. They are still not back to their health status that they had before they had COVID-19. And again, this can range from mild to severe enough to be a disability. For some people, it's just kind of annoying. And we've talked to some people who say, you know what, I've got this ongoing cough, or like maybe I can't run as far as I used to, but like it's not that big of a deal. I'm not going to seek medical attention. Maybe it'll go away. Others are completely bedridden after the COVID-19 infection. Next slide, please. So what are some of these potential symptoms? I used some graphics that came from New York City that really highlight some of the more common ones that we hear. Some of these can be, even if somebody has one symptom, if it's a really severe one, it can actually still be pretty debilitating. So having more symptoms doesn't always make it worse. But some of the more common symptoms include cough, difficulty breathing or shortness of breath, fever, rash, difficulty thinking or concentrating. And this is sometimes called brain fog, though I think that really does a disservice to how severe this symptom can be. When someone is having issue with memory recall and word finding or making new memories, they can't concentrate very well, their thinking feels really slowed. That can really impact their everyday life and their job and their relationships. So it's brain fog, I feel like sounds a little bit less serious than it actually is. New headaches and migraines, changes to smell or taste, or a loss of smell or taste, profound tiredness and fatigue, mood changes, or new anxiety or depression. Next slide, please. There's also chest and stomach pain, changes in menstrual cycles, diarrhea and other digestive issues, joint and muscle pain, pins and needles feeling, especially in fingers and toes, symptoms that get worse after physical or mental activities. So this is known as post-exertional malaise, or PEM, and that can occur not just after exercise, but even something like taking a shower, doing the laundry, and now all of a sudden they need to go lie down for a couple of hours. And even strenuous mental and emotional activities can cause some of this profound fatigue. Sleep problems, dizziness on standing, and lightheadedness, and that can include fainting, fast beating or pounding heart, known as heart palpitations. So again, not all of these symptoms are going to occur together. It may be very different from person to person. And really these impacts to like the autonomic nervous system, which is regulating our heartbeat, and a lot of different organ systems, those are the ones that can be the most debilitating. Next slide, please. So who can get long COVID? Well, the short answer is anyone. There are people who were young and healthy before they had a COVID-19 infection who now have long COVID. I talked to people who were athletes, even in college, and they are now unable to walk around the block without having to use a mobility device. People with mild COVID-19 can get long COVID. Some people barely had symptoms when they tested positive, and then weeks or months later begin to have some of these other symptoms. That said, the risk is higher if the COVID-19 was severe when the person was initially sick. If they required hospitalization, they're at even higher risk. And some of that is because of some of the interventions that can happen with hospitalization, like the ventilators that were happening, especially early on, or somebody being in the ICU for a long time. That can cause a whole other cascade of issues called post-intensive care unit syndrome. So the worse the infection, the more severe the illness in the acute phase, it does increase the risk of long COVID. People who already have health issues, like diabetes, is definitely one that seems to be coming up again and again in the research. HIV, kidney disease, mental health issues, being overweight or obese, asthma or autoimmune disease. These are all things that if someone has a diagnosis, or maybe they're pre-diabetic, or has any of these conditions, they may be at higher risk for post-COVID conditions as well. People who are unvaccinated and not boosted, this is another one where the emerging research continues to support that getting vaccinated can really help prevent some of these long-term complications. There may be a genetic component. They've identified a couple of genes that may make people at higher risk for these, but we're still learning there. Long COVID may be more likely in women and people who have a uterus, and especially that autoimmune version of long COVID seems to be more likely there. And that's not too much of a surprise because autoimmune conditions tend to be higher in those populations as well. And there seems to be some hormonal components to a few of the phenotypes. So that is a factor as well. People of working age are also the biggest group of people who seem to have been impacted by long COVID. So we're still learning about who and why is impacted. Next slide, please. So what's the impact on communities? This is something that NDH is actively trying to gather some more information on, and others around the country and the world. So we're still learning, but what we know is that there were lots of inequities before COVID hit in terms of social determinants of health and pre-existing conditions in communities. We also know that there was a greater exposure to the virus, especially for frontline workers, people in living situations where it was harder to avoid COVID. And those same folks may have had less access to prevention, like vaccines, less access to healthcare. And so all of that together probably means there's more long COVID in those communities as well. And so some of the folks that we've been working directly with for some of our efforts include the BIPOC communities and immigrants, LGBTQIA folks, people with disabilities. I'll talk more about that overlap shortly. And then rural and low income areas across the state. Next slide, please. So how common is long COVID? Well, this is hard to pin down because we don't have one definition for long COVID yet. We're actually probably talking about multiple different conditions. And so the estimates range very widely. MDH and CDC and others have sort of narrowed it down to say that somewhere around 5 to 30% of adults with COVID-19 will have some kind of longer term complications. It doesn't mean that they're permanent. It might just mean something that takes several months to go away. But that is kind of the going estimate right now. CDC data is showing that it seems to be decreasing as these milder variants have been in circulation. But it does plateau kind of around 10% in a lot of their data. Children and teens also can have long COVID. Thankfully, it's lower in those populations, but estimates there can range from about 1 to 15%. And then a subset of those folks, maybe 1 to 2%, that also varies, will have the severe long-term symptoms. So when I say 5 to 30%, I'm talking about anybody who's having some kind of like cough that sticks around for 2 or 3 months, or maybe like they don't feel as sharp mentally for several months. A lot of people see resolution at 6 months or by 12 months, but some people will have those longer term, really debilitating symptoms. And again, thankfully, this is decreasing as we have more vaccinations out there and variants are milder, but we don't yet know what the consequences of multiple infections are, and people are getting reinfected, 3 and 4 times at this point. And also for people who did struggle to recover from their initial COVID illness, they may experience relapse if they get infected again. Next slide, please. So long COVID and disability is a really important area for us to focus on because there are multiple layers of overlap. For one thing, we know that folks with disabilities were disproportionately impacted by COVID-19. Again, less access to preventive measures, healthcare, and accessible information, some increased exposure risks when you have, home health aides, lots of situations where people may have been disproportionately impacted. They may also have certain underlying conditions that increase their risk for long COVID. So people with disabilities are definitely susceptible to long-term complications from COVID-19. There's the other side of it as well, where long COVID can also be a new disability. And some have called it the largest new entrant to the disability community in modern history. Again, we know it is a small percentage of people who will have these long-term or permanent disabling symptoms. However, because so many people have had COVID and will keep getting COVID at this point, even if it's only, half of 1% of the population who have been infected, when 80 or 90% of people have gotten COVID, that can still add up to a lot of people. The federal government has recognized this, and long COVID can qualify as a disability under the ADA if it is causing substantial limitations to a person's abilities to complete daily tasks. So that is something we have a lot of resources around, and we'll talk more about. Next slide, please. So what can somebody do if they think they might have long COVID, or somebody they know and love might have long COVID? If symptoms are interfering with daily life, it's really important for them to talk with a healthcare provider. For one reason for that is because, as mentioned, many other conditions share these symptoms, and there might be something else going on, like diabetes, like chronic kidney disease, and the provider will be able to identify and then help them treat or manage that. The most extreme example I've heard of this is where somebody assumed they had long COVID because they were having all these symptoms, and it turned out they actually had a brain tumor. So it is really important to seek out care if somebody has new symptoms that are interfering with their daily life. There is no cure for long COVID, and I'll talk more about treatment and management in a bit, but there may be some strategies available to relieve or manage some of the symptoms, and a provider can help with that. Also, a provider can document changes in health or loss of function, and that can be really important for things like workplace accommodations, disability claims. So that documentation piece can be really important as well. All that said, it is not without challenges, and you can go to the next slide, please. Right now, providers are still facing some of their own challenges with long COVID. There's not one way to diagnose or treat it. So there's not like a single test that they can just give you and say, oh, you have long COVID. It's often this sort of process of elimination where they want to rule out other potential causes of the symptoms first. The provider also may not know what to do. We're still learning about ways of managing these symptoms, and treatments are in clinical trial phases, and there are some off-label treatments available, but not all providers know about the guidance that's out there yet. Some of them are a little skeptical of, frankly, long-term chronic conditions after viral illnesses, and this is a long history of stigma around people who don't bounce back from acute infections, and I'll talk more about that. Some other challenges for patients is that it may require a lot of appointments and specialty care. Somebody might need to see a heart doctor or a lung doctor. They may need physical therapy or occupational therapy. That can be a big time commitment as well as expense if it's not covered by insurance. There may be long waits for the specialty clinics. This is getting better anecdotally. There are specialty clinics throughout the state, but also more health systems have teams who are coordinating care for long COVID. However, some of the bigger specialty clinics like at the U and Mayo Clinic may still have wait lists for new patients. All that said, again, still important to talk to a healthcare provider if somebody has new symptoms that may be interfering with daily life. Next slide, please. So what can providers do and what can people do for themselves also? I'll talk a bit about non-clinic strategies as well. But in the clinic, while there may be no cure, there are some treatment and management options out there based on the presentation of the symptoms, based on what kind of limitations they might be causing. Providers are learning from similar conditions and other strategies out there. So like for traumatic brain injury, there are some management strategies and occupational therapy that can help with, remembering things better, different ways of increasing concentration and managing symptoms that way. There may be other rehabilitation like physical rehabilitation to build the heart and the lungs back up, to help with when somebody's energy systems have kind of been hijacked, to help build that back up very slowly. There's even smell therapy that some clinics use if someone has a really drastically altered or lost sense of smell or taste, which can really impact your quality of life. There's a smell therapy out there that helps retrain those connections to the brain. There are also some medications that they can use in some instances. If someone's having heart palpitations or dizziness, there's different beta blockers and prescriptions that can be used for that. Low-dose naltrexone is a really interesting one that seems to be showing up a lot. It still has not hit the literature yet, but a lot of providers are prescribing it off-label. You may be familiar with naltrexone for people who are struggling with substance use disorders and overdose situations. In a very, very low dose, it can actually help with some of the inflammation and other issues that could be triggering the long COVID symptoms. People can also alter their diets. Sometimes cutting certain things out of the diet or changing eating patterns can help manage symptoms. And mental health support can be a really important one. Not because long COVID is all in somebody's head, but because especially if someone is dealing with a new chronic condition or a new disability, sometimes they need help just getting to a place of acceptance around what their new baseline health might be. It might be causing them a lot of anxiety because there's so many unknowns. So getting that mental health support can be really important. For some people, it may involve pacing, which is basically strict rest periods after acute COVID-19. And this is for the people with that really profound fatigue and post-exertional malaise. They learn to identify their what's called an energy envelope, or you may have heard spoon theory for people with chronic conditions, and it helps them reserve their energy in ways that allows them to continue to meet their daily goals. And hopefully sometimes then they can gradually increase activities to get closer back to their baseline. There are a lot of unproven home treatments out there, or treatments like, bariatric chambers and some other very expensive medical treatments as well that are still yet unproven and can be really expensive. Just because it works for someone else doesn't mean it'll work for everyone. And there are a lot of people who see the desperation in people with long COVID and see it, unfortunately, as an opportunity to sell a supplement or something else that's completely unregulated. So just be really cautious about home treatments and some of that. Some people do get better with time. As mentioned, sometimes it might take 6 months or 12 months, but people do eventually seem to get better to baseline in a lot of cases, but not everyone does. We still have a lot to learn about who and why. Next, please. No, I'm getting short on time, so I'll move fast past the last part because I really want to make sure there's lots of time for the next presenters. I know they're really important. So some non-clinical support as well. We don't want to just think of the medical model here. There's such thing as support outside of the clinic, and that can be really important. So what that might look like is getting help with childcare, household duties, or daily activities while someone is recovering so that they can do that resting when they really need to. And I'm sure many of you know, some of us like take off our work hat and then put on our parenting hat, or like spend the weekend doing chores. Sometimes we need to sort of get help with some of those activities so that we can rest and take care of ourselves. So support from family and friends, neighbors, a faith community. This is a good time to ask for that. Pacing, I mentioned, can be an important strategy for conserving energy. There's also the wonderful Centers for Independent Living throughout our state who serve anyone who's struggling with daily tasks, whether or not they identify as having a disability. Peer support networks can be important because they can talk to others with long COVID who really understand what the lived experience is like. Workplace accommodations can be important for helping somebody keep their job while they recover. And other community and social services that are available. And I'll post some links to these resources in the chat shortly. Next slide, please. So I don't know about you all, but I'm interested in preventing long COVID in myself and my loved ones. I hope I haven't scared you all too much, but I will just remind everyone that risk is not just black or white. It's not binary. Risk is really a spectrum. And so we don't have to be all or nothing with risk. We can do things to protect ourselves while still engaging in life, while still being with people that we love. The best prevention for long COVID, the only way to guarantee you won't get it, is to avoid infection or reinfection with the virus that causes COVID-19. But I recognize that is getting harder to do all the time as fewer people are testing, or people are testing at home and not telling anyone if they test positive. People aren't wearing masks anymore, so it is getting hard to avoid that infection. But there are things we can keep doing, like wearing masks, monitoring the hospitalizations and different data for community spread, wastewater data, just being aware when spread seems to be going up, and maybe not going to that indoor concert with thousands of people if there seems to be lots of community spread happening. That's one of my sort of thresholds. Vaccination and boosters, again, while these cannot completely eliminate the risk of long COVID and long-term complications, they do seem to reduce that risk. Some studies are showing by as much as 50 or 60%. So because they help reduce that chance of severe disease, that's also just an important way that they may reduce the long-term impacts of the virus. Some potentially protective things that are still being studied. If you test positive, it's important to rest and not push through it. Take that time that you need, get help with chores and childcare so that you can rest and listen to your body. There's a lot of studies happening with potential medications during the acute infection. So things like Paxlovid, if taken within the first 5 days of infection, may reduce the occurrence of long COVID. We're also looking at metformin, which is really interesting. And supporting overall good health, keeping up with preventive exams, and to the extent possible, taking care of yourself kind of gives you better odds against this virus. Next slide, please. So I'm going to really briefly talk about what MDH is doing for long COVID. We have our long COVID program that was funded under the CDC Health Equity Grant, which is 2 years long and is going to be ending this coming May, but we are so fortunate that we were able to secure some ongoing state funding. So we're not only going to be sustaining those efforts that we had underway, but expanding them as well and adding some more staff. We also have money for grants and contracts, so you'll be hearing more about all of those opportunities soon. This is just a quick glance at some of our major activities of our program. You can see partnerships and engagement are at the top because relationships are really at the center of what we're doing. We know we need to be working with partners, people with lived experience, as well as technical expertise early and often if we want to do the best work possible here. So we have our Community Voices Partner Group. I'll talk a little bit more about that. We have health providers and systems on board, as well as people experiencing long COVID and their caregivers, other state agencies, ADA Minnesota, and others. And our kind of 3 main buckets of work are understanding the impacts of long COVID. So we're analyzing some results from a statewide phone survey that happened earlier this year, and looking at doing some more specific community assessments on the long-term impacts of COVID-19, analyzing existing data like claims and electronic health records, and looking at that overlap with other chronic diseases and mental health. We have our Guiding Council of Clinicians across Minnesota from, Mayo Clinic and Sanford and the U and big systems, but also places like Kook and community clinics and federally qualified health centers, North Memorial and others who serve a whole bunch of folks all over Minnesota. And they're really getting together as a learning network to share what they're seeing in their clinics, what some of their processes are, and as a work group for some more specific projects that are underway. But the focus there is really how can we increase quality access for everyone, and how can we help, the gatekeepers like primary care providers and others who are on the ground see long COVID and understand what they can do for people who may be experiencing it. And then education and resources, just trying to get awareness out there so people know this is a thing. It's possible that you might have some health issues after a COVID-19 infection, and what to watch for and what you can do about it. And then sector-specific presentations like this one, we presented to employers and school nurses and local public health and lots of other people, trying to get them to understand how long COVID might show up in their community or in their sector. And our goals, especially now that we have some grants and contracts, resources, would be to do some culturally relevant messaging from trusted messengers and community-specific support. So stay tuned there. Next slide, please. This is a quick screenshot showing the MDH web content for long COVID. There's 4 pages of content there, some background information, as well as resources and support information, a little bit about what we're doing at MDH, and then a page for healthcare providers. It's a bit more technical. Next slide, please. And this is a screenshot of the link tree at the top of our long COVID resources and support page, which is very popular. It talks about where you can get medical care for long COVID, mental health support if you struggle with daily tasks, some tools for managing symptoms at home, and then resources specific to the workplace, so for employees and employers, as well as resources for caregivers and schools and people who might be on the pediatric side. Next slide, please. This is a quick shot of some other communications efforts. We had a graphic that we made, and there are some, I'll share a link to the Facebook post that utilize that graphic, and we do have some just 30-second PSAs about long COVID that are translated into Spanish, Hmong, and Somali as well on our YouTube channel. So I'll share a link to that. Next slide, please. Just briefly talking about our Community Voices Partner Group. We recruited folks from the community, COVID community coordinators to be, hi Karina, I see you. No, but we don't have the graphics translated yet. I'm working on getting the right files so that we can share those. It's been a little bit more complicated than I anticipated, but that is something that is definitely of interest. Currently, our Community Voices Partner Group is meeting monthly, and these are folks from, right now it's Stair Step, ASER, the Southeast and Metro Centers for Independent Living, CAPI, African Immigrant Community Services, wonderful group who's coming together to help us understand what communities want to know about the impacts of long COVID, what resources would be helpful, how we might design some of these funding opportunities, and how else they would like to be involved. And so if you would be interested in learning more about our Community Voices group, again, we're meeting about once a month. We just had an in-person meeting a few weeks ago to go over the survey data from the phone survey, and they're helping us interpret some of those findings. But please reach out. I'll have my contact information in the chat shortly. We'd love more perspectives. We know we don't have like the whole of representation here, and we're not looking to just like check boxes and look at one person to represent a whole community, but we want to get as much input and understand what communities are asking and talking about as possible. Next slide, please. So I threw a lot of information at you very quickly. Thank you for hanging in there with me. Here are some key takeaways I want to circle back to just to help bring it kind of back up to the top. So the virus that causes COVID-19 can impact almost every system of the body in different ways, and sometimes this causes long-term health problems. Long COVID can refer to more than one condition. Symptoms can be very different from person to person. They might range from mild to debilitating. For some people, long COVID eventually gets better on its own. Others may get worse or have symptoms for many months or years. Long COVID can affect anyone, but some people and some communities may be at higher risk. Next slide, please. It's important to talk to a healthcare provider if symptoms after COVID-19 are interfering with daily life. Tests and treatments are still being developed, but they may be able to rule out other causes and help improve or manage symptoms. Staying up to date on vaccinations can help protect you from long COVID. MDH has a program seeking to understand and address the impacts of long COVID across our state. And this includes partnering with our Community Voices group and sharing what we know. Let us know if you'd like to connect. And while we still have a lot to learn about long COVID, we're learning more every day. More information and resources are at the website. I'm going to drop a bunch of links into the chat, including my contact information. And you can go to the last slide, please. Thanks very much. I look forward to your questions. I'll answer them to the best of my ability and knowledge. Sure. See, I think we'll just have to make sure these links are formatted in a way that they are going to work well in the chat. But I look forward to any questions that you have. Thank you so much.
We have a few minutes for questions. So are there any questions out there right now?
Hey, Amy, there's a question. I don't know if Katie was able to answer that says, are the long COVID infographics translated from Karina?
Yes, and thank you for asking that, Karina. Currently, they are not translated. That's something that we're working on. Well, we were hoping to compile them into one graphic. Right now, it's like what do you call it? Like a slideshow format, multiple graphics. And we got feedback that having maybe a distilled shorter list all on one graphic would be better. But I had some people interested in translating what we have. So I'm working with our graphics department to get the right files to potentially share on that.
Any other questions? I would like to ask my colleagues if you remember how to save the chat, whatever it's called, the chat section, if you could do that, or somebody copy it so we have that for the future.
Yeah, I have a question. Maybe thank you, Katie, for your excellent presentation on long COVID. Maybe can we give us these slides so that we can cascade to the, in our turn, we can cascade to our partner organization?
Can you repeat that? You want to go to another one of the other slides?
Yes, slides. Can either ways we can get the slides so that we can cascade to our partner organization?
Be able to share the slide deck.
Oh yes, this is being recorded. So once we have the recording, you will be able, we'll send it out and you'll be able to look at everything yourself.
Okay, thank you.
Amy, this actually is not it's not recording.
I clicked record.
Oh, okay, you didn't, I'm so sorry. I see it now. It wasn't announced, so I didn't hit record.
Yeah,
It is recording.
it's my
Okay,
fault.
thank you. Thank you.
All right. Well, with that, I think I'm not hearing any more questions right now. And if you come up with one later, you can certainly ask it. If Kate isn't able to stay on for the rest of the presentation, we can take your question and send it to her and get an answer. So we now will hear about COVID-19 and the updated vaccine from Caitlin.
Good afternoon, everybody. My name is Caitlin. I'm one of the nurses here at MDH. I'm going to provide you with a COVID-19 vaccine update today. Next slide, please. So I wanted to give folks just a brief update on COVID right now. We are seeing some increasing trends for hospitalizations and urgent care visits, both nationally and in Minnesota. In Minnesota, the increases are small, but with the start of school, that may kind of change our trends. Much of the variant trends in Minnesota continue to be from the Omicron XBB lineage, and that is the makeup of the new vaccine. And I'll talk about that in just a bit. The Omicron EG.5 and FL.1.5.1. Those are the variants right now that are really, really growing. And, you know, we continue to be the most concerned for our highest risk groups, which, you know, are the elderly, pregnant people, children under 2, and those with weakened immune systems. Next slide, please. So I wanted to briefly just kind of discuss these COVID variants, and I think of them as kind of like a tree. On the bottom of the tree, you see there's a blue arrow with Wuhan. So the Wuhan strain was the original strain. And then as you make your way up the tree, different variants have emerged. So there's Alpha, Beta, Delta, and then Omicron. And that is like the family of variants that we are currently in. If you look at Omicron, and then right above that, it has BA5 and BA4. So that was the BA4, BA5 was what our bivalent, or our last vaccine, was made up of. Above that is that XBB that we've been talking about. And our 2023-2024 updated vaccines more closely targets that XBB lineage of that Omicron variant. So vaccine, you know, could restore protection against severe COVID-19 that may have decreased over time. And we do anticipate that these updated vaccines will be better at fighting the currently circulating variants. Next slide, please. So an updated, they are calling it a monovalent, so a single strain, an updated 2023-2024 COVID vaccine formulation was approved on September 11th. After it was approved, CDC's advisory committee met and gave their recommendations. They recommended the vaccine for everyone 6 months and older, and everyone ages 5 years and older is recommended to receive 1 dose of this updated vaccine. Now, children ages 6 months to 4 years, they may need multiple doses, and people who are immunocompromised should have 3 doses, with at least 1 of the doses being the new vaccine. And they also may receive additional doses based on their clinical situation. So they should speak with their healthcare provider. So with the authorization recommendations of these new vaccines, the bivalent vaccines are no longer recommended. And I did want to note that Novavax has not received approval yet. So we are still waiting for Novavax's updated formulation to be approved. Next slide, please. So we've been getting a lot of questions on.
Are you taking questions right away, or no?
I sure can.
I think what I'd like to do is go through the presentation and then have the questions after, because your question might be answered in the next couple of slides.
So that would be fine, but I think my question is based on the slide, so you might have to go back to the slide to help me look at it.
Okay.
I can certainly wait, but this is the slide I'd like to ask my question on if you want us to continue, but just so we can.
No, sure, go ahead.
I'm sorry, go ahead.
Yes, please.
Oh, okay, thank you. So on this slide, this is Janet. I'm from Duluth, Minnesota with Health Equity Northland, the executive director. And looking on this slide, the recommendations for 5 and older is receive 1 dose of updated. Now, does it matter if you've received a dose before or not?
So it does not. So it's 1 dose of this new updated formulation. And I should have added this 2 months after, at least 2 months after your last COVID vaccine dose.
Okay.
Does that make sense? Yeah. So it's just the 1 dose of the updated formulation for 5 years and older, at least 2 months after the last COVID dose. COVID
So
vaccine
folks
dose.
that haven't received a dose don't feel like they have to get caught up before they have to take this one, correct?
That's correct. So an unvaxxed, so if there is a person that has never received any vaccine doses, the recommendation is still just the 1.
Okay.
Now
then-
I just wanted to add one thing. So, but for children, 6 months through 4 years, if they had never received any vaccines, then depending on if they are getting Moderna or Pfizer, they would need multiple doses, but it's just for that age range if they're not vaccinated.
They maybe need multiple doses. And how is that determined?
It's the recommendations of the committee. And so, like, for example, like a 2-year-old that comes and has never received a COVID vaccine, they would need either 2 doses of Moderna or 3 doses of Pfizer vaccine. The younger kiddos and studies have shown that they just need more vaccine to kind of prime their bodies to build up that protection.
I see. So I'm having, and maybe this is down the road on the other side on how we educate people.
So let's keep moving on, and we'll have plenty of time for questions after the presentation.
Certainly. Could I go to the next point though? Because I need clarity on that one as well. The 3 doses.
Well, I think we'll continue on, and then you can save your question, and we'll get back to it.
Okay, thank you.
I think I just have one more slide left, but so we are getting a lot of questions on when are you up to date? And I did kind of touch on this. But as I said, everyone aged 5 and older, you're considered up to date when you get your 1 updated COVID vaccine. And then, as I also mentioned, those children that are 6 months to 4 years, they are considered up to date when they get all the recommended doses, including that 1 dose of that updated COVID vaccine. And then some folks also have asked about Novavax and Johnson & Johnson. So I did want to mention that people who have received Novavax vaccine, they are considered up to date when they get the Novavax vaccine doses that are approved for their age, or when they get 1 updated COVID-19 vaccine. And then people who have received the J&J vaccine, which is no longer around anymore, they are considered up to date when they get 1 of the updated COVID-19 vaccines. And I did include the link there, the Stay Up to Date with COVID-19 Vaccines. CDC just updated that a couple weeks ago, and there's a lot of great resources on that page too.
Caitlin, is the spike vaccine the same as the updated COVID-19 vaccine?
So it is, and the reason why it's a different name is Spikevax. It's the same formulation as Moderna. The reason that it is a different name is because it's fully licensed, and so for 12 and older, it's the Spikevax or Moderna. For 12 and older for Pfizer that received full licensure is Comirnaty. You might hear that name around, and that is the Pfizer version of that vaccine that is 12 and up. Did that help answer your question?
So I think that's the end of Caitlin's presentation. So are there any questions?
Yes, if you could go back to that slide that we were on that 3rd bullet, please. if you could just run through verbally the people who are immunocompromised. I understand it tells me right there, but hearing it is helpful than just reading it, because it really is confusing for those of us who are not doing this every day, all day long, and especially to health coordinators who are not even here. So having the ability to decipher this for them is really important. So I appreciate you running through that people who are immunocompromised bullet point.
Yeah, for sure. So this is pulled right from the recommendations. I do want to say something though. People that are moderately or severely immunocompromised, we really do want them to reach out to their healthcare provider. To determine if they do need additional doses based on their clinical situation, and then how far those should be spaced apart, etc. The recommendation, stated just people who are immunocompromised should have 3 doses. And so if, for example, if someone who is immunocompromised, say, has never received any vaccine doses, they would get 3 doses of the updated formulation. And then, subsequent doses thereafter, once they've discussed that plan with their healthcare provider. If someone has already received 3 doses of COVID vaccine, they would need 1 of this new formulation to kind of, bring them up to speed and up to date. And then again, they can have that conversation with their healthcare provider on any additional doses.
Could I ask one more question? So say they've received 2 of the earlier versions, would they still then need 2 of the new?
So then they would just need 1 of the new formulation.
Sorry.
So then they would have the 3 total. No, that's okay. Yeah, great
How about
questions.
if they receive 1?
So
If they receive 1, would they still need the 2 to add up to
would.
3? Okay.
I
Correct.
see that there's a hand up. So I see that Janet Kennedy has her hand up. Janet, do you have a question?
That's me talking.
Oh, okay. Great. There are a couple of questions in the chat, I think. One is, so for immunocompromised, our doctor is going to determine if we need 3 doses and how much time in between the doses.
Yep. So we really want folks, speaking with their provider, especially if they think that they need subsequent doses. And I'm just pulling up. I apologize. I'm just trying to look at the time frame in between the doses here, because I don't want to tell you something incorrect. And Lynn, I know that you're on too, so if you know right off the top of your head, feel free to.
I think it's 2 months between each dose.
Yeah, I believe that you're right.
And then for the updated formula that we'll probably see happen every year, for those who have weakened immune systems, they may be recommended to get another updated dose like 4 to 6 months later into the year. So it's possible we may hear something about a recommendation early next year for people who have weakened immune systems. And it just depends on how the virus behaves with its continued change.
Any other questions? We still have another part of a presentation to go about the bridge program, but are there any further questions for Caitlin and Lynn?
Yeah, Amy, this is Ryan from KFAI. Thank you, Caitlin and Lynn, for all this information. This is awesome. Is everyone, 6 months or older eligible right out of the gate as soon as they can make an appointment, or will there be priority given to like healthcare workers, long-term care residents and providers, or is everyone eligible?
Everyone is eligible right now if it's been at least 2 months since their last dose. It is important to note that, you know, this COVID vaccine, now that it is, you know, commercialized and on the private market, you know, it's rolling out almost like flu vaccine, right? So we're getting, you know, kind of waves. More is coming into this into the state, you know, each day, and then as the weeks go by, we'll be getting more vaccine. We don't have a ton right now in the state, but like I said, kind of like with the rollout with flu, it will just gradually continue to increase.
Which providers have it right now?
So you can that's a great question. So you can actually go on vaccines.gov, and you can throw in like a zip code or city, and it will bring up all the sites that have it. And you can narrow it by, you know, Moderna or Pfizer, and then you can see the locations closest to you that do carry the vaccine.
Thank you so much. Also, just one more thing, Caitlin, how do you pronounce your last name for future reference?
Yes, Stalin.
Thank you so much.
And just one more thing about vaccines.gov. Most of the clinics that are listed are pharmacies, so CVS or Walgreens. If you want to know if your own provider has it, you probably are going to have to call. If that provider is part of a health system like an Allina or UHealth or mHealth, they may have announcements to their members about if and when and what products are available. So it will be similar to what people do with influenza when they each fall go looking for a flu shot. Some people have a doctor's appointment and get it right there, and some people will stop at a drugstore. So just so you're aware that not all of the clinics are listed on vaccines.gov.
Great. Why don't we move on to the next presenter, which would be Bilkis, because I see there's a question that Armando has in the chat about the monovalent being free and the bridge program. We might be able to answer that question in the next presentation. So with that said, we're going to hear from Bilkis about the Bridge Access Program.
Hi, good afternoon, everyone. My name is Bill Keys. I'm a Salon. I'm the program manager for the Bridge Access Program.
Bilkis?
Yes?
Bilkis, your audio is a little bit difficult.
Oh,
to...
let's see.
I think maybe if you stay very close to the microphone, it might be okay.
Okay, well, I'm just using my mic on my laptop, so I'm not sure. Does it sound better, maybe?
I think the closer you get, the better it will be.
Okay.
Yes.
Well, I don't know where my microphone is on my laptop, but we'll we'll try and make it work. I can also talk much louder.
Yeah, I think that's good.
Okay. All right, so hopefully everyone can hear me. Again, my name is Bill Keys. I'm a Salon. I'm the program manager for the Bridge Access Program. I'm going to be talking a little bit about what that is today. Next slide, please. All right, so before I get into what the Bridge Access Program is, I wanted to provide some additional context in terms of what exactly does commercialization mean? So when we say that the COVID vaccines, the updated 2023-2024 COVID vaccines are commercialized or on the private market, you know, how is that different than how vaccines were available in the past? So prior to this fall, this year, 2023, you know, we were in a pandemic, we were in a, you know, public health emergency. And so the United States government purchased all of the COVID-19 vaccines from manufacturers and provided COVID-19 vaccines at no cost to anyone, regardless of insurance coverage. With these new, again, the 2023-2024 updated COVID-19 vaccines, these vaccines have now entered the commercial market. And so now it is the providers. So if you think about, different pharmacies, different healthcare systems, your doctors, et cetera, these folks are now purchasing the vaccine directly from the manufacturers. And so what that means is that now, the federal purchase of COVID-19 vaccine is limited to essentially our safety net programs. And so there's the federal Vaccines for Children program. Here in Minnesota, we call it the Minnesota Vaccine for Children program, or MIN-VFC is how a lot of people will say the acronym. And then the CDC Section 317 program, which is the program that's used to provide vaccines to uninsured and underinsured adults. They're purchasing vaccine for that program as well. And here in Minnesota, we call it our uninsured or underinsured adults program, often abbreviated to the acronym UUAV. So with that right there, you can sort of see the vast difference, right? Going from the United States government purchasing all COVID-19 vaccines to federal purchase just being limited to those two programs. Next slide, please. So what does this mean, for everyone, right? what does this mean for the public in terms of costs associated with getting a COVID-19 vaccine? So the good news is that, most people with health insurance, and, that would also include Medicare, Medicaid, someone with a state-sponsored healthcare plan, like MNsure. For those folks, most plans will cover the COVID-19 vaccine at no cost. That said, again, because these vaccines have been commercialized, it's always a good idea to reach out to your health insurance provider just to make sure, right? We do know that there are some health insurance plans that were grandfathered in after the ACA was passed that may not provide full cost coverage of the vaccines. So there are some folks who, might have health insurance, but might have a plan that does not cover the full cost of the vaccines. And we consider those folks to be underinsured. So again, just want to reiterate it. These are the first COVID-19 vaccines to be commercialized. And so, there might be some costs associated with receiving them. So it's never a bad idea to just make sure and check. But for the most part, most people with health insurance will be able to get a COVID-19 vaccine at no cost. So for folks who do not have health insurance or have those health plans that don't cover the full cost of the COVID-19 vaccines, that is where, we have the federal Vaccine for Children program, as well as the federal Bridge Access program to provide COVID-19 vaccines to these folks. Next slide, please. Okay, so now we're kind of getting into the specifics here of what the Bridge Access program is. And so this is a temporary measure that started this fall, and it will last until December 2024 to make sure that uninsured and underinsured adults continue to have access to the COVID-19 vaccine now that they've been commercialized. So the Bridge Access program is able to make those vaccines available through 3 different ways. So through existing partnerships with state and local health departments, with local health centers. So if you're thinking about FQHCs, community health centers, those types of locations, as well as pharmacies. And so the CDC was able to continue their contracts with CVS and Walgreens. And so most CVS and Walgreens locations across the US will be participating in the Bridge Access Program. Next slide, please. Okay, so in terms of accessing a free or low-cost vaccine here in Minnesota, I just wanted to share what some of those options are. So again, I mentioned FQHCs and CHCs, our community health centers. And we'll post a link in the chat that has this information there as well. So folks can actually click on some of these links if they're interested in checking that out. So for community health centers, there is a way just to search to be able to find where those are located. So you can find one that is near you. MDH is continuing our community vaccination efforts. So if some of you are probably familiar with our CCCs who do a lot of vaccination events in the community. So those will be continuing to happen. So if anyone is interested in finding a community vaccination event near them, our COVID-19 public hotline is also still up and running. And those folks can call that number and get some information about those events. And then, like Caitlin and Lynn mentioned, vaccines.gov is where you'll be able to find those participating pharmacies who are a part of the Bridge Access Program. And again, Lynn did mention that right now, if you were to go there, you are going to see mostly just those CVS and Walgreens. But part of the Bridge Access Program is making sure that all providers that are participating in that program are up and running and are listed on that vaccines.gov site. So over time, we will start to see other providers populating that vaccines.gov site. Again, right now, it is mostly the pharmacies. We at MDH, we're still receiving information on how to get our other providers listed on vaccines.gov. And so as that guidance comes in and then we're able to get our providers listed, you'll see more options available there. All right, next slide. Okay, and so that is it for me. Just again, a brief presentation on the Bridge Access Program. Hopefully that answers the question that I see Armando put in the chat about whether or not the vaccine is free. Again, for most people, if you have health insurance, it will be free. And then for folks who do not have health insurance or are underinsured, the Bridge Access Program is providing those doses for free or low cost to those populations. And to answer that second part of the question, are pharmacies like Walgreens giving monovalent vaccines now? Again, you can go to vaccines.gov just to check and see if the CVS and Walgreens locations near you have the vaccine. Thank you, everyone. I'm also more than happy to take other questions as well.
All right, so thank you to the presenters. Are there any questions?
There's a comment on this question on the chat which says, what are the qualifications for the bridge program and how do people prove they are uninsured? And then also additional question on the chat from Armando.
Yes, so
sorry.
what are the qualifications for the Bridge program and how do people prove they are uninsured?
Yeah, that's a good question. So I can't speak for the pharmacy arm of that program. These are independent pharmacies that are run separately from MDH, but I do know for our UUAV providers that are participating in the Bridge Access Program, they will have to ask folks However, there is no documentation, so there's no paperwork to sign or anything like that. It is more of like a verbal attestation, if you will, if you are choosing to get your vaccine through one of our UAV providers. So in terms of the qualifications, again, it's folks who are uninsured, so meaning that you do not have health insurance, or underinsured.
So the question here is, are there efforts to reach our populations from the refugee, immigration, and low-resourced communities? Also, are there navigators to help them get the vaccine at no cost? I'm gonna quickly pop in that our grantees, who are the community engagement and diverse media grantees, are an important resource for our refugee, immigration, and low-resourced communities to get that information out.
Thank you, Amy. Oh.
Sorry, Sandra, this is Okash. Also to add that we also do have the COVID-19 community coordinators, or the CCCs, that are reaching populations from refugees or immigrants, as well as other communities.
Right, the CCCs serve refugee, immigration, low-resource communities in Minnesota. And you all should know about the CCCs. I think you should all have the calendar to see when their vaccine events are happening. They've been a little bit slow right now because I think they've been waiting for the new updated vaccine. So you'll have to just we'll keep you posted on that. And then I see there's a question, how long will the funding be provided? Is it ongoing?
If that question is about the Bridge Access Program, that is through December 2024.
Was that what you were referring to from Poland at KU? Yes, okay. Other questions?
If we're directing, hi, Ryan again from KFAI. If we're directing our listeners to community vaccination events, are people who both uninsured, underinsured, and those who have insurance, can any of those people get vaccines at those community clinics still, or is it just people who are uninsured or underinsured?
Yeah, that's a good question. So I would encourage you to share with folks the bit about reaching out to the public hotline to identify the community vaccination events near you. The staff at the public hotline have access to that calendar and can see who the provider is. Most of our providers that are administering vaccine at those events will be able to vaccinate folks who have private insurance. However, I do know that there's one provider that is specifically only focused on providing vaccines to uninsured and underinsured individuals. And so it would depend on the vaccine event itself, based on which provider is working at that event. So it's a little bit complicated of an answer. I apologize, but you know, what I will say is that most of the community vaccination events will be able to vaccinate all folks. But again, I do know that there's at least one provider working on those events that are only able to vaccinate uninsured and underinsured individuals.
Thanks for that.
So
thanks for that response.
Yeah, I suspect as the flyers come out and the information about the events come out, they will say who will get insured, who will get vaccinated, and who will have to who will take uninsured and insured, and who will take those with insurance. I see there's a question. How soon after you have had COVID can you get the new monovalent vaccine? Are the symptoms after getting monovalent going to be the same as before? So that might be for Caitlin or Lynn.
So are you referring, when your second question, are the symptoms after getting monovalent going to be the same as before? Are you talking about maybe like side effects after getting the vaccination?
I think if you've had COVID-19, if you just had the virus, how soon after you've had the virus can you go and get the new monovalent vaccine? Does it make a difference if you get it right away, or do you need to wait?
So people who recently, and I did put a response here in the chat, but people who recently had COVID, the recommendations say that they may consider delaying that vaccine dose by 3 months from symptom onset or positive test if they didn't have any symptoms. And the reason is after someone has had COVID infection, your immune response is still pretty good. You're pretty protected for a few months from getting COVID. And so that's why the recommendation says you might want to consider delaying that next vaccine dose by the 3 months. And studies have shown that if you do delay getting that, that your body actually does form a better immune response if you wait versus if you've just recovered from your isolation period with COVID and you go out right away and get that vaccine.
So Caitlin, am I hearing you say that it's up to the individual?
So it is up to the individual. Lynn, maybe you want to add some other thoughts in here. But yeah, the recommendation currently does say they may consider delaying that for 3 months.
Yeah, as Caitlin said, the illness or vaccine is going to give your antibodies a big boost, meaning that you've got what you need to fight off another COVID infection for a while. And so you can, waiting is probably going to allow you to take advantage of that annual dose. If you wait until, let's say you just got over COVID last week, if you wait until November or even December to get that dose, you're still protected during that time. And then you can get your one-time updated vaccine, and that will last you throughout a much longer period of time. There are a lot of people who, having experienced COVID, want to get vaccinated right away, and that's perfectly fine as long as they're not needing to be isolating themselves from others because of their illness. If they're over their illness, they can get vaccinated as soon as that. It's just inside knowledge that it really is okay to wait a few months to get that dose. It'll just stretch out your protection even longer.
Thank you. There was a question that came in a while ago, and I don't know if you can answer this. This might be a question for a physician, but is it possible to get COVID-19 and the flu at the same time?
Fortunately, yes, it is. And we have seen this throughout the pandemic.
Okay. And getting the flu shot and the updated vaccine at the same time is okay to do, correct?
Yes, it is. You can get them at the same time.
Great. Any further questions? All right, well, thank you so much to our presenters. This was wonderful, wonderful information. Thank you for taking the time to join us and pass out this information. It was so helpful. Thank you so much to our interpreters today. We love having them here, and thank you for all for joining us and learning. Certainly, if you have questions in the future, you can send them to your grant manager, and we will seek to find answers to your questions. So once again, thank you so much for everything, and I want everybody to have a wonderful rest of the day.
Thanks, Amy.